Hello everyone and welcome to a new session of clinical pharmacology and drug therapy. Today we are going to speak about non-steroidal anti-inflammatory drugs. I am Dr. Khalid Hassan, professor of clinical pharmacology and drug therapy from University of Maryland Institute. We are going to speak about the acetaminophen, about the Tylenol brand name, aspirin, diclofenac, Voltaren. So we are going to cover the most popular medication in the clinical practice. Let's start it. Okay, so as I mentioned, our topic, non-steroidal anti-inflammatory drugs. We, as you can see here, we have the group of medication, non-steroidal anti-inflammatory drugs, the class of medication that commonly used to treat, commonly used to reduce pain, treat inflammation, and treat fever. Okay, the class of medication on the list here, very popular medication. We have ibuprofen, naproxen, aspirin, diclofenac, indomethacin, ketorolac, piroxicam, meloxicam, celecoxib, etodolac. This is the most common NSAID in the practice. So what happened here? We have two codes here. What we have here, the blue highlight. This is over the counter, no prescription needed. So ibuprofen, naproxen, aspirin, ketorolac is no prescription needed. And what we have, the red color here, the red background here, celecoxib, meloxicam, etodolac, considered like selective COX-2 inhibitor. So we have two codes here, the blue background and the red background. The blue background belong to the over-the-counter popular prescribing medication. Then the red background belong to the COX-2 inhibitor. Okay. Speaking about NSAID, non-steroidal anti-inflammatory drugs, in order to understand the medication, how the medication work, we need to review we need to look on the cell membrane. In the cell membrane, we have something called membrane phospholipid. So this one available in the cell membrane phospholipid. And the membrane phospholipid, we have enzyme called phospholipase A2. This phospholipase A2 enhance conversion or formation of arachidonic acid. So we have arachidonic acid as a substance formed under the effect of phospholipid and the membrane phospholipid. This will lead to two main pathways. The first pathway will be lipooxygenase, and the second pathway will be cyclooxygenase. So two main pathways. So we have lipooxygenase and cyclooxygenase. For cyclooxygenase, as you can see here, we have cyclooxygenase 1 and cyclooxygenase 2. Okay, from the previous lecture, if you go to the lecture with the allergic rhinitis, we discussed leukotriene with you. So you can see here in this image, here in this picture, leukotriene is considered like the pathway of lipooxygenase. So the enzyme responsible for formation of leukotriene called lipooxygenase. Okay, moving to the next, what we have here, according to the cyclooxygenase enzyme, we have several prostaglandin will be formed. As you can see here, cyclooxygenase 2 responsible for formation of different type of prostaglandin, and one of the most important type called the prostaglandin. Another name for prostaglandin is called the prostacyclin. Okay. Moving to the cyclooxygenase 1, and this was like housekeeping or homeostatic mediator, and responsible for formation of prostaglandin and thromboxane A2. And what happened here? They tried to remind us cyclooxygenase 2 responsible for formation of prostaglandin. This prostaglandin lead to the sensation of pain, sense of pain, fever, and inflammation. So prostaglandin responsible for pain, fever, and inflammation. What else? Prostacyclin, BGI2, prostacyclin, decrease platelet aggregation. Prostacyclin cause vasodilation. We need to remember this one here. On the other hand, for cyclooxygenase 1, and this responsible for gastroprotection, renal function, and thromboxane A2, TXA2. This will lead to, when you activate this type of prostaglandin, this will lead to the increased platelet aggregation and cause vasoconstriction. So we need to remember this function here. And someone, maybe we look there, we look to the opposite action between thromboxane A2 and the prostacyclin. Thromboxane A2 increase platelet aggregation, prostacyclin decrease platelet aggregation. We have type of balance here between the two pathways, so we have balance here. Okay, what happened here when you prescribe NSAID? The patient suffers from pain, fever, or inflammation, and you prescribe NSAID to your patient. What happened there? So we try to figure out here from the slide. So you prescribe, you can see here, we prescribe NSAID to the patient. The NSAID inhibit cyclooxygenase 1 and 2. NSAID, we call NSAID in general non-selective, inhibit cyclooxygenase 1 and cyclooxygenase 2. Okay, as you can see from this image here, NSAID inhibits cyclooxygenase 1 and cyclooxygenase 2. Okay, but however, when you prescribe celecoxib, let me clean this one here. So you can see here the NSAID inhibit cyclooxygenase 1 and cyclooxygenase 2. Okay, so if you inhibit cyclooxygenase 2 with the NSAID, if you inhibit cyclooxygenase 2, the result will be decreased pain, decreased fever, and inflammation. That's good. But what happens when you inhibit cyclooxygenase 1? The result will be remove the protection from the GI system, remove the protection from the renal, and increase the risk of platelet aggregation. So all these considered like side effect or adverse drug reaction of NSAID due to the inhibit COX-1 inhibitor. Okay. Okay, with the effect of celecoxib, you can see here, celecoxib, selective inhibitor of COX-1. Okay, celecoxib, selective inhibitor of COX-1, and this provide benefit for the patients from peptic ulcer disease, for example, here. So celecoxib is drug of choice for patients from arthritis plus peptic ulcer disease, and this medication will be drug of choice because this medication preserves the effect of prostaglandin on the GI system. Okay, cortisone, we prescribe cortisone. How the cortisone work? The cortisone inhibit enzyme called phospholipase A2. Now we understand three main mechanisms of action. Number one, celecoxib, selective inhibitor of COX-2. NSAID, non-selective inhibitor. Then we have glucocorticoid or corticosteroid inhibit phospholipase A2. Okay, let's us look on the what we have on this case K2 now. As you can see here, we have cell membrane phospholipid, and this under the effect of phospholipase A2 lead to the formation of arachidonic acid. Arachidonic acid under the effect of cyclooxygenase enzyme COX-1 and COX-2. This will lead to the formation of prostaglandin, several types of prostaglandin. As you can see here, we have prostaglandin D2, prostaglandin E2, prostaglandin F2 alpha. We have prostacyclin, we have thromboxane A2. All these will be formed under the effect of arachidonic acid cyclooxygenase pathway. When you prescribe NSAID to your patient, such as ibuprofen, diclofenac, naproxen, and this will inhibit this enzyme cyclooxygenase. So NSAID group of medication inhibits cyclooxygenase enzyme. However, they try to remind us this inhibitory effect of NSAID will be reversible. That means it's not permanent. The only exception, aspirin. The aspirin inhibits cyclooxygenase irreversibly. So this is the main difference between aspirin and other NSAID. So aspirin irreversibly inhibits cyclooxygenase. Okay, what happened there? So as you can see here, aspirin, or another name, generic name or chemical name, acetylsalicylic acid, Aspirin reduce inflammation, aspirin reduce pain, aspirin reduce fever here. So all these effect of aspirin in the treatment. For example, when we use aspirin or NSAID, okay, this will lead to reduce inflammation, pain, and fever. Okay, another important, very important table to compare. This table compare between the agent belong to the prostaglandin. So we have prostaglandin agent here. Then we have leukotriene. So we look on prostaglandin E2. We look on the prostaglandin F2 alpha, prostacyclin, thromboxane A2. We have the abbreviation in the previous slide. I recommend you to review the previous slide. Thromboxane A2. TXA2, then we have BGI2 stand for prostaglandin, prostacyclin, then we have LT stand for leukotriene. We have several types: leukotriene B4, leukotriene C4, leukotriene D4. We look on the effect of these mediators on the organ and cells tissues. We look on the vascular tone on the blood vessels, what happened there on the blood vessels. We are going to look on the bronchial tree. We are going to look on the uterus, the platelet function, look on the chemotaxis, and we have some effect called unknown effect. In general, prostaglandin cause vasodilation. In general vasodilation. We have one exception, if you can see here, thromboxane A2 cause vasoconstriction. Okay, vasoconstriction here with the F2 alpha vasoconstriction, thromboxane A2 vasoconstriction. Okay, what about bronchial tree? Okay, thromboxane A2 bronchoconstriction. What about uterus tone? The main prostaglandin in the uterus will be F2 alpha. Okay, cause uterine contraction, the main one. But in general, E2 cause vasoconstriction and F2 alpha cause vasoconstriction. Okay, the most important maybe effect here when you look on the platelet. The platelet agglutination. So what happened here? Thromboxane A2 increased platelet aggregation. On the other hand, the opposite effect will be prostacyclin decrease platelet aggregation. So again, we have a scale here. We have balance. As you can see here, we have balance between prostacyclin. We have balance with thromboxane A2. Thromboxane A2 increase platelet aggregation, risk of clotting, and we have prostacyclin decrease risk of clotting. Leukotriene responsible for chemotaxis, bring the inflammatory agent. Inflammatory agent will be bring to the area and cause inflammation, chemotaxis, leukotriene in general. Another important maybe change here, looking on the bronchial tree, we can look on the leukotriene. Leukotriene cause bronchoconstriction. Leukotriene cause bronchoconstriction here. So if you go back and review the asthma and COPD, you can notice there we have some medication belong to the anti-leukotriene. So we have some medication belong to the anti-leukotriene used for asthma, such as montelukast. Okay, so we have medication for asthma like anti-leukotriene.